Good afternoon, class. Please, can you hear me?
Good afternoon. We can hear you.
Okay. Please, I'm Yvonne, a member of Group 6, and we are presenting on pain management in children. So this is our objectives, and we are saying by the end of this presentation, each student or each of us should be able to describe what pain is and state the types of pain we have, and then assess pain using the pain assessment tools. And then lastly, describe the types of pain management. So we are saying, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So it is actually caused by a stimuli, so a stimulus. So it is felt by the individual who is experiencing the pain. And then we are saying pain can be very mild or severe or even explosive. So types of pain, we have acute pain, and then anything acute starts suddenly, and then we have chronic pain, which can be pain due to an underlying cause. Then we went ahead to misconception about pain in children. So we are saying here that healthcare professionals once believed that children feel less pain than adults. So there was undertreatment of children due to this idea perceived by health professionals. And research has shown that these past beliefs about children's perception of pain were incorrect. And then even the smallest infants do feel pain and remember it. So we are saying that it is not only adults who feel pain, but even the smallest infants feel pain. So effective pain management is every child or infant's right. And the reality of pain in children. So by 20-week gestation, a fetus has the most of the anatomic and functional requirements for processing pain. Term infants have the same level of sensitivity to pain as older infants and children. Preterm infants may actually have greater sensitivity. So as the baby is in utero, all these pain processing structures in the body has been established already. So they feel pain even as much as preterm infants also feel pain. So infants express pain with both behavioral and physiologic clues that can be assessed. And when we say behavioral, that is how the child behaves, how the face is he timid, has he frowned the face, or he is crying. And then the physiologic clues, these are also measurable things that can be assessed to know to know the type of pain the child is going through. So children use distractions to cope with pain, but they soon become exhausted when coping with pain and then fall asleep. So normally you can sing for the baby, you can give the child its favorite toy just to move the child's mind away from the pain he is feeling. But when they become exhausted, then they fall asleep. So we moved on to pain assessment. And then here we are saying pain assessment is a broad concept involving clinical judgment based on observation of the type, significance, and context of the individual's pain experience. When assessing a child's level of pain, careful consideration needs to be given to their one, cognitive ability. Is the child able to converse, know where he is, how he is, or like effective communication? Is he able to use his mind effectively? And then the environment, is it a hospital setting? And then anxiety or cause of pain. What is the cause of the child's pain? Is the child anxious or he is acting normal? So we have 3 ways of measuring pain. We have self-reports, what the child say, and then that is the golden standard. We are saying that because pain is felt by an individual, and what the person is feeling is what it is. So you can't just say the person has a brighter face or is not crying, so he's not feeling pain. It is what he says, that is what it is. And then we have behavioral, how the child behave. Is he timid? Is he lethargic? Or he's crying? And then physiologic, that is clinical observations. Is the respiration up? How is the oxygen concentration and all of that? Those are measurable observations. And then the test we do, the vital signs, all those are part of the physiological observations. So we go on to pain assessment tools. There are 3 main tools used for the neonates, infants and child. That is 3 to 18 years. These tools reflect a combination of behavioral and self-report assessments. So the combination of these 3 tools, and then we have one, which is the FLAG, the combination. It is actually an acronym of F stand for face, the L stand for legs, A for activity, and then the first C stands for cry, and then the last C stands for consolability. So we are saying this is a behavioral type of pain assessment tool we have, and then it is used for children 2 months to 8 years, and also used up to 18 years for children with cognitive impairment or developmental disabilities. So in this case, the mother or the caretaker will be present for the nurse to assess this type of pain tool. And then 2, we have the Wong-Baker Faces Pain Scale, which is assessed by looking at the person's face, and the person is this is a self-report assessment tool. So the person will just look at the faces and will tell you where he falls, and it is used for children 3 to 18 years, 3 months to 18, 3 years to 18 years. Yeah. So this is the FLAG skill, and then we are saying this is the behavioral type. So the each category is scored on a scale of 0 to 2, which results in a total pain score between 0 and 10. So the person assessing the child should observe them briefly and then score each category according to the description supplied. And we are saying FLAG has a high degree of usefulness for cognitively impaired and many critically ill children. So the first, the F is the face. So is that the 0 means no particular expression or smile. 1 is occasional grimace or frown, withdrawn, disinterested. And then 2, frequent to constant frown, clenched jaw, quivering chin. Then we have the legs, the L, the legs. Is the legs not in normal position or relaxed? 1, uneasy, restless, tense. 2, kicking or legs drawn up. When you come to the activity, is the baby lying quietly? Is he in normal position or moves easily? 1, squirming, shifting back and forth or tense. Then the 2, act rigid or jerking. We come to the cry, and that's where we have is the baby. Oh, okay, the baby is not crying. Awake, no crying. Is it awake or asleep? Moans or whimpers, occasional complaint. And then 2, crying steadily, screams or sobs, frequent complaints. Then the consolability, is it content, relaxed, or under 1, reassured by occasional touching, hugging, or being talked to, distractible. And then the 2, we have difficult to console or comport. So if a child should score all these face, legs, activity, cry, consolability, all 0, then we are saying there's no pain or very little pain. And if a child should score 2 for each face, legs, activity, cry, consolability, then we are saying that is the worst pain they have ever felt. So we move on to the next 2, which is the Wong-Baker faces pain scale. And we are saying this is the self-report type. So you explain to the person that each face is for a person who feels happy because he has no pain, or sad because he has some or a lot of pain. So phase 0 is very happy because he doesn't feel hurt at all. And then phase 2 hurts little bit. Phase 4 hurts little more. Phase 6 hurts even more. And then phase 8 hurts whole lot. Phase 10 hurts worse. So if there's no pain at all, the baby is happy. And then the phase 10 is the worst type of thing the baby is going through as at that moment. So we move to physiological indicators of pain. And when we say physiological, I mean these are measurable biological functions that provide insights into the health and well-being of the baby. So how is the baby's heart rate? Is there an increase in heart rate? So an increase in heart rate may occur. 2, blood pressure may increase, oxygen saturation may decrease, more rapid or shallow or irregular breathing. And then you are saying physiological indicators in isolation cannot be used as a measurement of pain. We are saying this because maybe the oxygen saturation may be okay, there will be no shallow or irregular breathing, an increase in heart rate may not be present, and other physiological indicators, but the child may be in grave pain. So we cannot use only these physiological indicators in physiological aspects to indicate pain. So we went to pain management, and then under the types, we have 1, atraumatic measures. So this, under atraumatic measures, we have prevent or minimize child separation from family. And then what we mean is that allow the parent or caregiver to be present for painful procedures. They shouldn't be detached from family. The person taking care of the baby should be present. At least it will give the baby a sense of belongingness. And then we move to promote a sense of control. That is by offering choices to the child to give them some control over procedures. That is involving them in their care. And then prevent or minimize bodily injury and pain. And so you prepare a child for procedure or treatment, you control pain, provide privacy, encourage play for expression of fear or aggression, provide choices, and then lastly, you respect cultural differences. Then under the types, we also have non-pharmacological management. So you can oral treatment with a sweet tasting solution. And then this can be done with 24% of sucrose solution. So 2 ml, just 2 ml of this solution will be given to the baby, and then we are saying that it had a long run activates endogenous opioids, and by doing this, these opioids promotes natural pain relief. So as the opioids are activated by the sucrose in the baby's mouth, it kind of gives them pain relief. So we went to comforting the baby during and after injection, breastfeeding the baby during painful procedures, cutaneous stimulation, that is by gently rubbing the painful area, massage the skin gently, and hold or rock the child, application of heat and cold, and then guided imagery. And then we went to pharmacological management. So these are accepted doses for acetaminophen and ibuprofen. So under acetaminophen, we are saying 10 milligram per kg per dose in units, and then 50 milligram per kg per dose within normal limits in older children. And then under ibuprofen, we have 10 milligram per kg per dose is considered within normal limits. So some pediatricians insist the child must be able to eat or drink to avoid irritation to the stomach. These are references. Thank you. And then our group members. Sister, I'm done.
Let's hear from the floor. Do we have any questions for them? Do we want further clarification from them? Let's hear you. That's if you were following them. Okay, so if you don't have any question for them, then can you take off your slides so the next group will come and present? I think we have a lot of presentation to be done. So you have all this information, majority of them in the handout. And then the few, if you were listening to them, then you would have been jotting them down. The few that they have added, you'll be jotting them down. So the next group, let's have the next group share their slides. Safwan, Celestine, class reps, where are you? Which group is here to present? So we have group 1 has presented, group 5 has presented, group 2 has presented, group 4 has presented, group 3, I think you were presenting last week. Group 3, are you there?
We presented already. That was the very day you were having the network issue. You asked us that we should continue with the presentation, and you couldn't come on again.
Yes, so that's why that was last week. That was last week. Is that not it?
Yes, it's that.
Yes. So now we are left with which group just presented?
Sister, group 6.
Pain. Which group just presented?
Sister, group 6. Yes, please.
All right. So group 7, how many groups do we have? We have about 15 groups, right? So can we have the next group presenting? Group 7, where are you?
Sister, please, we are here.
So can you share your slides? Group 7, Group 8, Group 9, Group 10. You have all not presented. So what are you waiting for?
Yes, Sister, please, I'm about to share my slide for group 7. Or by if another group is ready, they can present. I'll share my slides soon. This group 7. Oh, okay. Okay, so please, this is group 7. We are presenting, my name is Gifty Adamale. We are presenting on drug and fluid calculations and administration for neonates and pediatrics. So this is our outline. We have the introduction. We have formula for drug. We will talk briefly about what goes on with drug administration when it comes to neonates and then the pediatrics. And then formula for drug calculation, IV therapy. We'll talk about pediatric catheter gauges. We'll talk about pediatric drug administration. We'll also talk about neonatal and pediatric fluid requirements, normal fluid maintenance, and then blood products, and then transfusion reactions. So our objectives for this presentation is that by the end of the presentation, we'll be able to know the formulas for calculating various drugs for neonates and pediatrics, know how to calculate drugs for neonates and pedics using their weight, age, and then body surface area, know the various fluid requirements for neonates and pediatrics, know what goes into blood transfusion for neonates and pediatrics, and then know how to administer orals, subcutaneous, and then IM medications to neonates and pediatrics. So with our introduction, we said that drug administration to children requires safe and effective measures combined with professional competency, best available evidence, and then liaising with the children and families. So when you talk about drug administration with regards to the units, we know that for you to be able to administering drugs for kids is very difficult, and you need to have some special skills and then some special knowledge to be able to administer drugs for medication. It's actually complex as well because you need to know how to calculate and give the right dosage of drugs to the kids in order to prevent them from having any adverse reactions. So, and in order to also achieve that aim, you should be able to liaise with the children and the family. So you, just like the way we behave with the adults, when we are going to administer drug, we explain to them, we need to also have that connection with the kids too, when we are going to administer medications to them, and also their family. They also need to know that the mother or whoever is with the child at the facility. You also need to explain to them and involve them in the drug administration process when it comes to kids. It says all practitioners must be accountable and be aware of the legislations and then professional regulation and guidance, such as the NMC 2015 and then NMC 2010. So what this is also talking about is that as we health professionals, we should be able to be accountable. We should be accountable when we are administering drugs to the kids or the children on the ward, that we should be able to know what exactly we are doing. So in case of anything, we can explain ourselves and we can tell why we are giving this or why we are doing this. And we should know the various legislation that regards drug administration when it comes to the new needs. And then most pediatric doses are calculated by weight or body surface area. We'll go more into that. And also, we should also know that when you miscalculate drugs for kids, because they are not able to voice out what is going on, the harm caused to them is very is high, because they're not able to voice out whatever is going on with them. So by the time if you are not observant very well, by the time you realize that the worst has happened. So if you are calculating drugs for children, you need to know the correct dosage. You don't need to miscalculate, because they are trying to let us know that it contributes to 1/6 of the medication errors, and the potential harm cost is threefold. So it's 3 times what the harm that happens to adults when we miscalculate their drugs. So this is actually a skill that I did a little bit of research and we got. That's talking about how to calculate drugs using the body surface area, the weights, and then here they gave their heights. So we'll talk more about it in our slide. So the knowledge you need to know about the drug and the patients when it comes to especially children, when you're going to administer drugs to them, that you need to know that one thing is that every health personnel is legally responsible for the correct administration of drugs. So as you are a health professional, wherever you find yourself, don't say that maybe because I don't work at the pediatric ward, so I don't work at NICU, so I don't know how to administer drugs to children. But this slide, this point is actually saying that we are legally responsible for the correct administration of drugs. So if you don't know, at least your hospital may have the protocols that you use in order to be able to calculate the right dose of drugs for your children. And the need for accuracy in measuring and administering drug is greater in adults than in it is greater in children than in adults. As I said earlier on, the last point under the first slide, that if you miscalculate drugs for children, the harm cost is 3 times that of an adult. So it's very important that you need to know the correct measurements. You need to know the correct measurements and adequately calculate the dosage for of the medication you are giving before you administer it. Be sure that you are giving the right dosage before you administer it to the children. And doses vary with the size of the surface area of the body, and then the weight and age of the child. So we have various calculations, and we have calculations that has to do with the weight of the baby, calculation that has to do with the body surface area, and a calculation that has to do with the age of the child. And we also say preparation of the child is necessary during drug administration, as well as explanation to the mother's understanding. As I explained earlier on, that before you administer drugs to a child, you need to involve the child, and then you need to prepare the child psychologically as well. Because there are some children, when they see you in the uniform alone, they are running away. They feel you are coming to give them an injection or something. So they are scared. They feel you are coming to harm them. So they are scared of we that we wear the uniform, nurses. So you need to prepare the child psychologically, physically, and everything, including the mother. Explain to the mother why you are giving this particular drug to the child, so that they will all be involved in the care of that child. And you must know the pharmacology of the drug that you are administering. That's a side effects, the drug interactions, and all the contraindications and all that. You need to know all those things before you administer the drug to the child. So we come down to the formula of drug calculation. So actually there are various formulas. We'll come down to that. But one thing that we need to understand is that when it comes to children, the drugs that are given, sometimes they come in grams or milligrams. You need to know the various conversions that you need to do in order to be able to administer the exact amount. They may give you a drug in grams that you have to administer to the child in milligrams. So you need to know how to do the conversions so that you'll be able to give the right and accurate dose. You have to know how to give the right and accurate dose to that child. So these are some of the various conversions of units, and then weight conversions as well. So I won't delve much into it, but we'll give out the slide and you can just go more into it. And then we'll talk about the various, we have one of the commonest calculations that we use as the dosage, the desired dose over the dose at hand times the quantity, that's the quantity of solution or drug times equals to the amount that you are going to give to the child. So this is some of the, this is one particular drug calculation. So there is a question here that a physician orders 1,500 milligrams of liquid ibuprofen for a patient. Quantity of ibuprofen is 500 milligrams in 1 cc. And then what does the 1 cc means like 1 ml of syringe. So what volume of ibuprofen would you administer to the patients? So here, the 1,500 milligrams is a desired dose, and then the dose at hand is 1,000. The dose at hand is 1,500. It's a 500. Sorry, the dose at hand is 1,500, and then you are supposed to the quantity of solution or drug, that's the 1 cc over the 1 cc over the 1. So you calculate that and you get the dosage that you are going to give to your child. So there is an example that we gave under this calculation. So we can all work it out and see how much this child will be taking or the patient will be taking. And we have another calculation formula called the Clark's rule. And this one uses the weight of the child in pounds. So we have that in the countries that use pounds and the countries that we use kilograms more. So we have a formula in kilograms. So with the kilogram on, we have so the pediatric dose is equals to weight of the child. Sorry, it's supposed to be off. Weight of the child in kilograms over 68 kilograms. So there's a formula times the average dose, and we are average adult dose. And you say that the average adult dose is a recommended dose for the adult medication use. So we have an example here that a pediatrician orders for a child weighing 50. So this one is in pounds. So we can convert, as we saw the conversion, so we can convert the pounds into kilograms. Then we'll be able to get it in kilograms. That's if we want to calculate in kilograms. We can convert the pounds into kilograms. Then we use it for our calculation. And the prescriber wants to calculate the dose. Sorry, I think I've skipped. Yes, so the pediatrician orders for a child weighing 50 lb to receive IV amoxicillin. The average adult dose is 600 milligrams. What quantity of amoxicillin will be needed for this child? So you use the formula and then you calculate to get your correct dose. We have another formula called the Frye's rule. And this one uses is used to calculate doses of infants less than 1 year. So mostly the neonate, those who are less than 1 year old. We use this Frye's rule to calculate the drug that they are supposed to take, or the quantity or the amount of medication that they're supposed to take. So the formula is infant's age, that's in months, over 150 months times adult dose. So that's a calculation for that as well. So that one too, we have a question under it that we can use in our free time. We can use that to calculate to see how much that child will be taking. And then we have the Young's rule. And then the Young's rule is used to calculate doses for children between the ages of 1 to 12 years. So if you're in the pediatric ward, you have children between the ages of 1 to 12 years, you use this rule to calculate the medication for them. And the formula is child's age, that's in years, over child's age plus 12 times average adult dose. Sorry. So you use this calculation for children who are between the ages of 1 to 12 years. And then the formula that uses the body surface area. Sorry, my laptop is so I have to use my phone. Sorry, you cannot see this. I think most of it has covered it. It wasn't like this on the laptop, but so with this one, the child's body surface can be determined from a nomogram, which is a more precise way to calculate. So the formula here is the surface area of the child, that's in square meters over the dose times the average adult dose. So anytime we are calculating, so when you look through the formulas that we put, the various formulas, you realize that all the calculations, they have to use the average adult dose, because the drugs that they are available, most of them come to the adult dose. So if you have that, then you use that to what in your calculation. So there's a formula for the body surface area, when you're going to use the body surface area to calculate for the dosage of drug that the child should receive. Now we come down to displacement values, and then we are saying here that, please just a second. So with the displacement values, we are saying here that some drugs require reconstitution with the diluents before being administered in liquid, since they are available only in powder form. So drugs such as maybe the child needs to take IV amoxicillin. It comes in the powder form, so you need to dilute it with aqua before you serve that medication. Before you serve it to the child. So with those drugs, you need to be able to know the amount of fluid that you need to mix with the drug, the powder, to be able to give the correct amount of dose, the correct dosage to the child. So the actual amount of powder adds volume, which is called the displacement volume. And then displacement value needs to be taken into consideration when reconstituting these drugs in order to ascertain the correct concentration of the drug. So here so I just placed a small table here of some of the drugs that we mix before we give to us. That's cefotaxime, flucloxacillin, the benzopenicillin, amoxicillin, and then the vancomycin. So these are the drugs that we mix with aqua before we serve. These are some of the drugs that you make before you serve to the children. So using this table, I wouldn't go much into this so that we don't spend much time on it, because our slide is quite loaded. So we can just go through this and then we will see what we are talking about. So we come down to IV therapy. Now, before we were talking, I just said that some kids also take IV medications, like the IV fluids and then the IV antibiotics and all that. So why do we give IV therapy? The purpose of IV therapy is to correct fluid and electrolyte imbalances, to administer medications, to administer blood products, and then administer nutrients. And then we also have the reason. The reason is to provide water, electrolytes, and then nutrients, and also to replace water, correct electrolyte deficits. Now we come down to the pediatric considerations. That's when it comes to IV therapy. That's a toddler or prescriber. We have to prepare the child immediately prior to the procedure. So before you think of setting a line for a child, you need to prepare the child prior to the procedure. You give simple explanation in concrete terms. You explain that you will hold the child. You'll be able to you help hold the child still. And then you emphasize on that the IV is not a punishment. Because when some kids, when they see needles, then they are just running away. And then you also, when it comes to infants, you need to be able to handle them gently and speak to them softly. You need to avoid the use of thumb sucking. And then CODeL immediately after insertion. So when you pass your IV now, you need to CODeL, the baby, because they'll feel pain. You know, they are kids, they react. So you need to be able to CODeL them. Sorry, some of the slides, you don't feed immediately prior to insertion, and then you need to avoid the presence of extra personnel to minimize stranger anxiety. So you need to also do that. So avoid those things in order to be able to pass your line to successfully to your baby. Now we have some of the various parts of the body that you can pass the line. So we have the frontal vein. You need to know that where you find some of the veins so you can pass your line. So if you are not getting it at the usual places that you get, you know that you can get it at any other parts. The arm, the forearm, the hands, the forearm, the feet, and then the scalp. Those are some of the places that you can get veins to set your IV line. And then we come to the various catheter sizes. And then, but we have the pediatrics one. With a newborn, the size used is 24 to 22 gauge. And we know that with the IV, the catheters, the higher the smaller the needle, the smaller the size. The higher the gauge, the smaller the size. So with newborns, they use 24 to 22. And then infants less than 1 year and greater than 1 year and older, they also use the 24 and 22. So mostly with the newborns in Ghana, for me, I haven't really seen the mauve one before. But the common one on the walls is the yellow and then the blue cannula. Those are the ones that come in the 22 and in the 24. So those are the ones that we mostly use. And then with the calculations of the pediatric, the complications, of pediatric IV therapy. So we have infiltration or extravasation. With infiltration, occurs when the IV fluid or medication leak out of the vein. It's like or the surrounding tissue. So you pass the line probably, and then you start seeing that the fluids that you are giving is like it's coming out. So the whole plaster that you've applied to secure the line starts it becomes moist or it becomes wet. Then you know that line you need to is a complication. So that line you need to remove it and then repass another one at a different place. We have the catheter blockage or occlusion. And with the blockage or occlusion, we have when it's blocked, maybe there's a clot or bubble in it, it can occlude. So when you are trying to pass any fluids, it will not go through. If we have air embolism as well, we have phlebitis, that is the inflammations of the veins. And then we have thrombophlebitis, we have infection, and then we have the metabolic derangement. So there are some pictures here for you to see what we are talking about. So when the first one, when it's infected, that's how it looks like. When there is phlebitis, when there is infiltration, that's when we mostly say that it's tissue. There's extravasation, there is hematoma, and then air embolism. So when you see any of these signs, you know that you have to remove. You don't have to continue your medications through that part. You have to remove it and then set up another line elsewhere. Factors influencing pediatric drug administration. We have the physiological differences. And when we talk about the physiological difference, it talks about the when it comes to the administration of the drugs, we have immature kidney and liver function. So when the baby is the kidneys or the livers are not matured, that can also affect your drug administration. When there's low gastric emptying time, it can affect your drug administration. We have gastric acid secretion in children under 3 years of age, lower concentration of plasma proteins, drug interactions, tolerance. We have purity and potency. So these are the various factors that can affect or influence pediatric drug administration. So these things can prevent you from administering drugs to a baby, a neonate or a child. That's to drug administration. Before you be able to administer drugs to a child or a neonate, you need to be able to calculate a safe dose, which should be in milligram per kg. Calculate the amount to administer. It should be in mils. So that's why you calculate the final concentration or dilution for IV medications. You calculate the rate of infusion. You set up the pump accordingly. You flush. You can flush the blood. That's like same as the rates that you administered it. Or the same as the rates that you're administering your drug, so you can flush as well. And then, so now we come down to neonatal fluid requirements. Neonates require greater amount of energy to maintain adequate weight gain, growth, and then development. And then the 10 baby needs about 100 to 110 kilocal calories per kilogram per day to maintain an adequate intake of nutrition. So when it comes to a neonate, they need about 100 to 110 calories per kg per day in order for them to survive or have adequate nutrition. And preterm needs about 120 to 140 calories per kilogram per day to maintain adequate growth and development. And the majority, as a majority of preterm infants are on it, because majority of infants are unable, preterm infants are unable to swallow effectively. Total parenteral nutrition needs to be
Julian. Oh, Sister Dora, please.
I'm fine. How are you?
Dora, Gigi,
I'm fine. I'm fine.
Anita,
please.
What is happening?
Hello, Sister Peace. I think I was just taking off. I don't know what really happened. So please, I'm continuing. Okay, so we're talking about the fluid requirements for neonates. So we said that with the first 3 days, there's an increment of about 30 mils per kilogram per kg per day. sorry, and then from the 4th to the 7th day, there's an increment of 10 mils per kilogram per kg, which I was explaining earlier on. Then also, we are also saying that with the day 8 and beyond, it's maintained at 180 mil per kilogram per kg until probably the child is able to suckle well. So this fluid requirement regimen is mainly for preterm infants. But there are in extreme cases, there are some slight changes that may happen. Maybe the child have to be on it for a very longer time, or that child is an extreme preterm baby. That baby may not need this specific regimen. There may be some adjustments made to it. So that's one thing we should actually take note of. So this regimen is mainly for the average preterm infants. That's those between the gestational age of, let's say, 34 to 36. But those below will probably need a well-adjusted one for them to be able to develop well and grow well. Fluids for a term baby, continuation of our fluid regimen. Fluids for a term baby rarely goes above 150 ml per kg, even if a baby is on nil per os. So with term baby, why is this so? Because for them, they are term. I mean, their various organs are a bit well developed that they can adapt. They can be able to, even if they are on nil per os, they are well matured enough. So they will be able to survive with 150 or below. But with the preterm, they are not, because most of their organs are not well developed. And we previously looked at some of the factors that can influence, and we talked about immature lungs and then liver and immature gastric. I mean, babies whose stomach is not well developed and all that. So that's why the preterm will need more fluids than an average term baby. And then babies who suffered hypoxia at birth, that's asphyxiated baby, are restricted to 40 milligram per kg per day in the first 24 hours. Why is this? This is because with the hypoxic babies, due to due to the fact that they were not able to have oxygen due to the deprivation of oxygen in their system, you need to monitor them very well. So with this kind of babies, you need to restrict fluids to up to just 40 milligram per kg in the first 24 hours before you can start increasing the fluids daily as the time goes on for them. And then growth retarded infants in utero or born to diabetes type 1 may have fluids commence a day ahead. That's the 90 mils per kg per day on day 1. So that's the IUGR, babies who are extremely low, those who have low birth weight by their term. So that's the IUGR babies or babies born to diabetes. That's a macrosomic. They need this there's a fluid requirement of fluid regimen for them on their day 1. And then older infants suspected of having patent ductus arteriosus, that's the children with their heart conditions, are often restricted to 120 ml per kg per day to prevent additional strain on their heart. And then intravenous fluids are titrated gradually as milk feeds increase to maintain total fluid volume throughout. So when the baby starts feeding, you now have to start reducing the IV fluids that you are giving. So you start titrating, you start reducing it. So you wean baby of the IV fluid totally, and then now the baby will now solely depend on their breast milk or whatever feed that the baby, or milk, or that the formula milk or whatever that the baby will be taking, then you use that one. So depending on how the baby is, the baby is developing, then you can start that weaning off the IV or the intravenous fluids. We have so what we talk about earlier on is for newty. So we have that of the pediatrics as well. It said pediatric fluid calculations are based on maintenance dosage using a percentage system. Fluids are calculated initially assuming that the child is receiving maintenance fluid, that's total fluid of that's required in 24 hours. So the normal fluid maintenance, it's actually categorized in 3 groups. The other one is not coming. So we have a child weighing greater than 10 kilogram, and then we have a child weighing 10 to 20 kilograms, and a child weighing less than a child weighing greater than 10 to 20, less than 10 to 20, and then greater than 20. So for a child weighing less than 10, there's 100% maintenance fluid, which is equal to the 100 ml per kg per day. So an infant weighing 7 kilograms, this is the amount, this is how you are going to calculate it. So you multiply the 100 the weight by the 100, that's 100 ml per kg per day, then you get your fluid for 24 hours. So it means if the baby is weighing 7 kilograms, the total fluid, the fluid required for the 24 hours is going to be 700 mils. In the whole of 24 hours, that baby should take about 700 mils. And then if a child is weighing 10 to 20 kilograms, 10 to 20 kilograms, we have you use the first formula. That's let's say a child weighing 10 kilograms, you multiply the 10 times the 100 mils the 10 kilogram, that's the weight times the 100 mils per kg per day, which will give you 1,000 mils plus another you get your 1,000 mils. But if the child is weighing 15 kilograms, if the child is weighing 50 kilograms, so the first one, you use the first formula, that's the 10 times the 100, you get your 1,000 mils plus you have 50 mils per kg per day for every kilogram thereafter, 10 mils. So you have the 50 times 5 kilograms, which will give you 250 mils. So in all, the child is a child weighing 15 kilograms will take 1,250 mils of IV or 1,250 mils of fluid in 24 hours. And then a child weighing greater than 20 kilograms, just as we did for the first one, he said you have 100 mils, you use the first calculation, 10 times 100 mils, and then the next one, 50 mils per kg. Then the second, the 50 mils for the per kg for the second 10, and then 20 mils per kg for every kilogram thereafter. So let's say, for example, a child is weighing 25 kilograms. So the first one, 100 times the 10 kilograms, which will give you 1,000, and then 100 times 50 times the second 10 kilogram. That's which will also give you another. That will give you 500 kilograms, and then the 5. So the kilogram that comes after that one, the remaining 5 kilograms, you multiply by the 20 mils per kg, then you get your total fluid for a child weighing 25 kilograms. 25 kilograms. So that the answer you get will be the total fluid calculation for the whole 24 hours. So that's the amount of fluid that baby should take for the 24 hours. So the fluid restricted. So if a child fluid is restricted for any reason, fluids are calculated using a percentage or fraction of the total requirements. So for example, if the child is 35 kg, as mentioned above, was restricted to 75% maintenance or a 3/4 maintenance, he or she would receive. So this is something that we'll have to calculate, which I explained earlier on. So a calculation of the drop rates. So we said that before before this whole slide started, we talked about the steps you need to take in order to administer drug for a patient. You need to also know the drop rates. Especially if it's IV fluid, how many drops per minute or how many drops per hour should this IV fluid be flowing for that infant? So calculating the number of mils to transfuse per hour. So if it's going to be per hour, the formula is the volume in mils over the time in hours. Then it will give you mil per hour. So if the child is taking IV, let's say 200 mils of, no, let me even use the normal 250, the small, the normal saline, that the one fake normal saline comes in 250. So if the child is going to take that, you need to know how many mils should drop in an hour. So the 250 mils over the time. So how many hours you want that to if is it for 8 hours? So if it's going to be for 8 hours, then you use that. So the 250 over the 8 hours, then it will give you your mil per hour. So then you know how many drops should be flowing within an hour. And then calculating IV fluid rate in drops per minute. So if it's in minutes, we know that we have to convert. If it's in minutes and you have the time in minutes, fine. If not, you have to convert the hours into minutes in order to get your accurate calculation, and also to get the accurate dosage for the child. So volume over in mils over the time in minutes time the drop factor, it will give you the flow rate per minute, the flow rates per minute, IV flow rates per minute. So with this one too, when you have your IV, the doctor writes a prescription that gives this. So there's an example here that calculates the IV flow rates for 1,200 mils of normal saline to be infused in 6 hours. So, and then the drop factor that was given is 15 GTTS per mil. So you use a formula to calculate. So here is an hour. So you have to change the hours into minutes for you to be able to get the flow rates in drops per minute that you want. Continuous intravenous infusion, that's if you are going to continue like giving a maintenance dose of infusion. We said that this is mostly for neonates and pediatrics. It's mostly prescribed on it's milligram per kg per hour basis. It's not microgram, it's milligram, sorry. The formula is the dose, that's in milligrams, plus the volume in mils, plus the weight, then times, then you convert, if it's in milligram, convert the milligram to microgram, then times the weight, that's a mil per hour. Then your final answer is going to be in microgram. Sorry, this one is a microgram per kilogram per hour. So when you get such, but there is something that we need to note, that when it comes to drugs such as dopamine and dobutamine, they are calculated on microgram per kilogram per minute basis. So it doesn't use hours, it uses minutes when it comes to giving drugs such as dopamine and dobutamine. So you now have to convert your hours into minutes in order for you to be able to calculate such drug for the infant or the neonate, sorry. So we now come down to blood products. So what are some of the responsibilities that a nurse should know when it comes to administering blood products to neonates or infants on the ward? The nurse must know why a specific product is being given to the child or the infant. And also you should know the safe volume over a safe time has been ordered. Common side effects of giving the products. No solutions other than normal saline or 5% albumin should be given in IV tube being used to give the blood products. So here what they are trying to say is that when you are the IV, that's the infusion sets that you are going to give, that you are going to use to give that blood product. Let's say it's blood. They are going to set up blood on the baby, blood transfusion. You should not, no solution should pass through that. So it's not the blood and the IV fluid, the giving sets that you use in giving the IV fluid that you use for the blood transfusion. No, actually we have blood transfusion IV IV giving sets that we use or infusion sets that we use. So mostly it's from the lab. You don't get that from with my facility, you get it at the lab. So when you go for the blood, they add that 1 to 2 it, and then you bring it to, you use that to administer your blood product. And then once a blood product has been issued from the blood bank, transfusion must be completed within 4 hours. And then also tubing is changed after blood products are given unless another unit follows immediately. So when you are, in case a child is to take another unit of blood, if it's readily available, you can use the same IV infusion set to give that blood. But if it's not, you need to remove it. And then when later on, don't remove the blood bag and throw away and say, oh, because the child will take another one, so let me keep this infusion, the tubing that you used to give the first blood, let me keep it down and then use the same thing. No, you don't have to do that. If it's not immediately that you have to give the second unit, you don't have to do that. But if it's immediately the 2 units are available, you give one, then you can use the same one to give the next one. And then most infusion sets are limited to 4 units and all are limited to 4 hours. So the infusion sets that we used to give our blood products, they are limited to 4 units of, so you can use, if it's, like I said, if it's immediately that you're going to be giving that 4 units of blood, you can use that same A, but if not, you just have to change it. All blood components must be administered through an infusion set with inline filter. So yes, and that's the chamber, the giving set chamber. So there's some nets inside. Mostly the blood giving set that we use, infusion set that we use, there's a net inside. So if there's a clot, it will be able to, the clot will not be able to pass through the tubing. It will get stuck in that chamber. And then platelets, FFP, and then cryo precipitates do not need to be cross-matched. So we are saying that platelets, I mean, if a child that needs fresh frozen plasma and all that, you need not to cross-match. That's what they are saying, that you don't have to cross-match such bloods, that before you give it to them. Note, routinely 15 to 20 ml per kg is given over 4 hours. That's the blood that we are talking about. That's for you to be able to transfuse a baby with a blood. We give 15 to 20 ml per kg over 4 hours. And then infants may be given IV furosemide midway through the transfusion. And then it is estimated that the HB level of an infant increases by about 2 to 3 grams per deciliter at this dose. So it's estimated that per the child's weight, if we are using this 15 to 20 ml per kg, with each transfusion that you do, there is an estimated increment of 2 to 3 grams per deciliter of that child's HB level. That's if you use this particular dosage. That's a 15 to 20 ml per kg. So we now come to assessment, administration, and transfusion. Assessment, administration, and transfusion reactions. So complete assessment prior to administering blood transfusion must be done. You observe the patient during the first 5 to 10 minutes of transfusion. You complete the assessment at 15 minutes into transfusion. Then you hourly you check your vital signs, the IV sites, and then to note for any complication. Maybe there was some infiltration or anything. And then as well as 1 hour after transfusion, then you now document. So these are the assessments that you need to do after you've transfused your baby or a child on the ward. These are some of the assessments that you need to do before you assess before, during, and then after. And then after, you document all that you have done for that child during the transfusion process. And then if transfusion reaction is noted, immediately stop and notify the physician. So let's say during the transfusion, the child start reacting, rashes and all those things. You need to notify, stop the infusion immediately, and then receive attend medication. So these are some of the blood compatibilities, and I mean, which blood type is compatible with which blood type for you to be able to know the blood adequate blood group that you need to give to your child or the infant on the world. Pediatric oral medication. Most pediatric drugs come in suspension or syrups. Solutions may be measured using an oral syringe, a small plastic cup, an oral dropper, or a measuring cup. So when you're giving oral medications to a child on the ward, we measure them using, you can have a syringe, some come with a small plastic cup with a measurement on it, some come with oral droppers or a measuring cup. And then suspension must be thoroughly mixed prior to administration. So before you give any suspension drug, you need to shake it very well so that everything becomes blends very well before you give that medication to the child. And it must be administered immediately after you've measured it. So don't measure it and put it down. Once you have poured it out of the bottle into the measuring cup or whatever it is that you are going to use to serve the medication, you need to serve it immediately. Do not place medication in a baby's bottle. So like the feeding bottles, don't put baby's medications into that bottle. And then never pinch a child's nostril to administer medication. Like, because probably the child is refusing to open the mouth, so you hold the nose so that the child will open the mouth by force and you pour the medication inside. No, it's not supposed to be done. And then you administer medications with a child sitting upright and head elevated in order to prevent aspiration. Okay, so you need to take note of that. And then mix liquid medications with less than an ounce of fluid to disguise the taste. So sometimes, there are some kids, so once they see that this medication, especially paralysis, if it's bitter, they wouldn't want to take. So you can mix with a little, with less than an ounce of fluid to disguise, to make them not feel the bitter taste that much. So you can do that. Then you serve it for that baby or that infant. Pediatric, so last but two slides. Pediatrics, subcutaneous and IV medications. Insulin and most immunizations are given subcut routes. The safe route of all injection sites is based on normal muscle development and the size of the child. So before you give, mostly, especially when you're giving the IV, IM medications, if some of the neonates, especially the preterm babies, you see that even there's no subcutaneous fats, there is no muscle. Even when you even want to give the Vitske right after birth, the baby is so bony, you don't even know how you are going to give this medication. So we are trying to say that safe use of all injection sites is based on a normal muscle development and the size of the child. Usually not more than 0.5 ml or 2.5 is injected per IM or subcut. So we are trying to say that if you are going to give an IM medication, it's usually not more than 0.5 mils in an infant. And it's also not more than 2 mils. Medication.
And was showing your son, yes, I'm quite for some. And I got to say, Mr. You mean it. Yeah, me, they will. Send me this.
Okay, sorry about that. So we are saying that when you are giving iron medication or subcast medication to an infant or a child, it should not be more than 0.5 mils in infants and then 2.5 mils when it comes to children. The usual needle length and God's pediatric clients use is there's half to 1 inch long, which and then the cannulas are 22 to 25 God. And the pediatric doses for subcuts and iron medications are calculated to the nearest 100 and measured using the TB syringe or the tuberculin syringe. So please, we are done with our presentation. If there is any question or clarifications, they are welcome. Thank you. These are our references, and then these are group members. Thank you.
All right. So the next group, if you have any question, you ask. If you don't have any question, can we have the next group present?
Hello, sister. Good evening.
Good evening.
Please, during the complication of, I think the IV, they made mention of air embolism, but I didn't get the explanation. Well, if they can throw more light on that, please.
So let them explain to you.
Okay, so yes, sister. Okay, so please, with the air embolism, sometimes when you draw an IV medication that you want to give, let's say maybe you want to flash, or you are giving your bolus, what's the name? Aniku, you are giving your bolus D10. So you draw it in a syringe. And then you have to make sure that there's no air bubble in the syringe. You have to make sure that there's no air bubble in the syringe. So when you look at the picture that I placed over there, when you are giving that IV medication and there's air bubbles in there, you end up introducing those air bubbles into the vessels and to end up causing an occlusion and then causing damage to the child or the neonates that you are taking care of. And then we are saying that this can be fatal. That's what causes the embolism, in adults or even in units. And also when you are giving iron medications as well to them, and then you don't make sure that once there is bubble in it, you are giving an injection, and whatever you are giving, there is a hole, it's passing through a hole. So if those bubbles are still inside, either be IV medication or iron medication, you end up introducing it into the baby's veins, and then you cause more harm than good to the child. So please, you understand it. So this embolism will end up occluding the vessels and can cause fatal maybe breathing problems. The baby will just be there and baby cannot breathe, or is gasping for air, or the baby's the heart rate is just rising, the baby becomes cyanosis all of a sudden. Those are some of the signs that you see when it comes to the air embolism. Then you know that something is going wrong with the child. So please, are you okay with the explanation?
Yes, please. Thank you.
You're welcome. Please, any other question or clarification?
Yes, please.
Okay.
Please, can you go over the normal fluids maintenance? I wasn't getting the calculation well.
The normal fluid maintenance. Please, which one? Is it this slide or this one? Please, which one exactly? Is it Okay, wait. Okay, is it this side? Is it this place?
No.
Please,
Yeah.
can you see this side? Is it this place?
Yes. Yes.
Okay. Okay. So we are saying that with a child weighing less than 10, with a child weighing less than 10 kilograms, the fluid that child should take within 24 hours. We have 100% maintenance of fluid. That's like that, which is equal to the 100 ml per kg. So if that child weighs about 7 kilograms, okay, so that child's weight times the fluid maintenance, which is 100% fluid maintenance, you multiply those both parameters and you get your fluid maintenance for 24 hours. So here there's an example that an infant is weighing 7 kilograms. So that child will receive how many mils of fluids within 24 hours. So you multiply the 7 times the 100 mil per kg per day. So we are trying to say that in about averagely, it should be like 100 mil per kg per day. But you use a way to calculate that. So if the child weighs 7 kilograms, you multiply by the 100 mil per kg per day. Then you get your fluid maintenance for the 24 hours for that child weighing the 7 kilograms. Did you get that point?
Yes, please.
Okay. And then with the second one, we are saying that for a child weighing 10 to 20 kilograms, we still use the same formula, but with them, let's say, for example, the child weighs 15 kilograms. Okay. So you first calculate for the first 10 kilograms. So with the first 10 kilograms, looking at the information here, it says that for the first 10 kilograms, you use the 10 times the 10 kilograms times the 100 mils per kg per day. Then you get that one. Then the other, you use 50 mils per, that's half of the 100 mils per kg per day. For any other kilogram that comes after the 10 kilogram. Please, you get that point. So with this one, it's 10 kilogram times 100 mils, then you get your first 100 mils plus 50 mils per times the 5 kilogram, because this child weighs 15 kilogram. So you wouldn't do like the first one that you do 10, then probably you say 100 times the 15. No, but for someone weighing 10 to 20 kilogram, you measure, you calculate differently too. That's the 10 kilograms times 100. Then you get your 1,000 mils plus the 50 mils per kilogram per day times the 5 kilogram, the remaining 5 kilogram. Then you calculate that one too. Then now you add both and then you get your total fluid for the first 24 hours. That's how come here the answer is 1,250 mils in 24 hours. Please, do you get this point too? Hello, please, do you get this point too?
Yes.
Okay. And then with the last one, they said if the child is weighing 20, is weighing more than 20 kilograms. So let's say a child weighing 25 kilograms. Here we are saying that you do your first calculation. That's your 10. You do the 10 times the. You do 10 times the 100. Then the second one, you do 50 times the 10, and then the 5, the remaining 5 kg, you multiply by the 20 mils. So the first 10, you multiply by the 100 mils. Then the second 10, you multiply it by 50 mils. And then the remaining 5 kilogram, so it's like you divide, you split it into 3 for you to be able to get your accurate fluid maintenance for the whole 24 hours for that infants. Please, you get it now. Sister, please, you get it now.
Okay.
From what you're saying, I get you, but what I want to know the 150 20, is it a protocol? Is it something that is there?
Yes, it's like, I think that's the protocol. So maybe your hospital may have a different protocol, but like it's like with this one, it's like the standard thing that is there, is being used. But your hospital may have, or your doctor may have it, your hospital may have its own protocol of fluid maintenance that they give to the neonates or the children in their units. So if your hospital have that fluid maintenance protocol, you can use that. But if they don't, you can use this formula to be able to calculate the number of fluid that the child should take within the 24 hours. Please, are you okay? Okay. So this is like a standard protocol that is there. Yes. Please, any other?
Yes, sister. Hello, sister.
Yes.
Yeah, please, I would like to find out the dosage calculation.
Okay.
Please, after using the different formulas, when you finish, are you going to put it back to the actual formula?
Please, which one is it? So with this one, when you look at the formulas, all the formulas are based, they use those formulas based on something. This is like a general formula that mostly we have the dosage required over dosage at hand times the quantity, they get the one that you want. But there are some other standard formulas that this one, the class rule is solely based on the weight of the child. Okay, so with the Clark's rule, you use that Clark's rule when you have only the weight of the child available. Then you use that one to calculate the medication that the child needs. And then we have the Fright rule, which is based on the it's used mostly for infants less than 1 year old. So the infant's age in height, in months over 150 months. So this has to do with like based on the age of the infant or the child. So we use the Fright rule and then the Young's rule based on the age. Because I told you, and in our introduction, we mentioned that for you to be able to calculate the dosage of the doses of infants medication or children's medication vary per the weight, the age, and then the body surface area. So that's why we have those various formulas. But then there's a general formula that we mostly use. And then we also have this other formulas. But I will also say that if your hospital also have a formula that you use for your at the NICU, they may have a formula that they use, then you can use that one to calculate the medication for the child. But these are the standard ones that are being used mostly everywhere. So we have the one that has to do with the age when you have the child's weight, and then the age less than 1 year, and then 1 to 12 years. Sorry. And then the one that has to do with the body surface area. That one is a little bit complex. So yes, but then this is what we have. Please, have I answered your question?
Thank you.
You are welcome, sister.
Hello.
Yes, sister.
But after class, post it on the page for.
Please, can you be a little louder? I didn't.
Page for us so that we can read.
All right, sure. Please, I'll do that. Okay. Thank you. Okay, sister, please, I think we are done.
Okay, so can we have the next group?
So please, we are group 9 and we are presenting on cyanotic heart defect or lesions with decreased pulmonary blood flow, atresia tricuspid, and cyanotic heart defect or lesions with mixed blood. Please, with the learning objective, by the end of this presentation, all students should be able to 1. Describe cyanotic heart defects or lesions, tetralogy of Fallot, arterial tricuspid, cyanotic heart defects or lesions with mixed blood flow, clinical manifestation and treatment. And for the purpose of our presentation, we have some diagrams here to show the various hearts, the normal ones and the ones that are not normal. And with the first one, that's the normal heart. We have the aorta, the right atrium, the left atrium, the left ventricle. Showing and the right ventricle to showing the right distance. So we move to the first. Please move. Please, the second one has to do with the tetralogy of Fallot. And if you take a look at it closely, we have with the first normal heart, we have the various divisions here well labeled. But with this one, you see that the aorta has shifted to the right instead of it being at the middle as compared to the normal one. So please move the distance up a little for me. And with the right ventricle too, there's an obstruction. But if you check the normal one, there's a vast, there's a line joining the two. But when you look at the abnormal one, there's an obstruction, thereby making it unable for the blood at the down here to flow to the top there. And there's another opening between the ventricles. That's the left ventricle and the atrium. If you check it very well, you see that there's an opening between them. Let's move on. So we move on to the cyanotic heart defect or lesions with decreased pulmonary blood flow. The first one has to do with tetralogy of Fallot. It is a congenital heart defect that consists of 4 heart abnormalities. We take the first one as pulmonary stenosis. This is the narrowing or obstruction of the pulmonary valve or pulmonary artery, which restricts the blood flow from the right ventricle to the lungs. So as we showed in the first diagram, over here, there's a restriction with the blood flow. Please move. We have the ventricle septal defect. It is the hole in the septum, into bracket, the wall between the lower chambers of the heart, into bracket, the ventricles. This will allow oxygen poor and oxygen-rich blood to mix. Instead of each of them going to the separate way, in this over here, there's a mix between the two. And we have an overriding aorta. In tetralogy of Fallot, the aorta, which carries oxygen-rich blood from the left ventricle, is positioned over the ventricular septal defect instead of arising from the left ventricles. This allows oxygen-poor blood from the right ventricle to be pumped into the aorta and to the rest of the body. So over here, instead of the oxygen-rich carrying it to the aorta for it to be distributed to the various parts, it is rather being pumped into the poor oxygen blood is rather being pumped into the aorta and the rest of the body. And we have the right ventricular hypertrophy. Due to the increased workload of pumping blood through the narrowed pulmonary valve, the right ventricle becomes thicker and more muscular, into bracket hypertrophy. And it is most common in cyanotic, into bracket blue baby heart condition. A fifth defect, either an open foramen ovale or an atrial septal defect, may also be present in some children. The pattern in this defect is determined by the degree of pulmonary stenosis. If the pulmonary stenosis is severe, pressure builds in the right shunt, that is producing cyanosis. If the pulmonary stenosis is mild and the pressure in the right ventricle is not increased, the blood shunts left to right through the and the child is acyanotic. In time, the pulmonary stenosis becomes more severe and the child becomes more cyanotic or less blood flow to the lungs. Hypoxic or tic spells occur in some children with tetralogy of Fallot. These spells are thought to occur as a result of transient increase in obstruction of the right ventricle outflow tract, causing cyanosis and a decreased level of consciousness. So please move on. And please, here are the clinical manifestation. One, we have cyanosis. With the cyanosis, there's blue discoloration of the tissue that results from increased concentration of reduced hemoglobin. So with the cyanosis, you see that the baby's hands and soles will become blue, sometimes with all the body included. And there's also hypoxemia. And with that one has to do with insufficient level of oxygen to the tissue. And there is increased hemoglobin and hematocrit. With the hemoglobin, that's the oxygen carrying capacity. So in order for the child to compensate for inadequate oxygen, there is increase in hemoglobin so as to help increase the oxygen level in the blood. And the hematocrit has to do with the percentage of volume of red blood cells in a given time. And there is a pan-systolic murmur, difficulty in feeding, clamping of fingers and toes, rapid breathing and breathlessness, squatting, poor growth, and fainting. So please move on. This is a diagram showing low oxygen levels in the blood, cause the lips, fingers, and toes to look blue. That is the cyanotic that we talked about. So in this case, you see that the soles of the baby's feet is blue, the hands and the lips, and even around the eye too. Please move on. Please, with the treatment, you have the teeth spell can be treated by placing the child in the knee chest position, which is thought to increase venous return to the heart and dilate the right ventricle, and should decrease the pulmonary overflow obstruction effects. And we have the ventricular septal defect closure. The septum is closed to prevent the mixing of oxygenated and deoxygenated blood. And we have the pulmonary valve repair or replacement. The narrowed or obstruction pulmonary valve is repaired or replaced to improve the blood flow from the right ventricle to the lungs. And we have correction of the aorta position. The aorta, which is often overriding the VSD, is repositioned to its normal position. And we have the right ventricular muscle relief. If the right ventricle is hypertrophied, that is thickened, the surgeon may remove excess muscle tissue to restore normal function. And if the surgical correction needs to be delayed, a palliative procedure may be done prior to a total correction in order to increase pulmonary blood flow. Please, you have the tricuspid atresia. So please, there's a normal anatomy here showing a tricuspid valve in the heart. And if you get to the other side, we have the type 1 tricuspid valve with ventricular septal defect. So with this one, please, those asking the VSD is ventricular septal defect, please. So if you check the other one, you could see that there's a solid tissue instead of the tricuspid valve. So this is rather blocking that space that is supposed to be here. Sister, please move on. And please, with the atresia tricuspid is the total occlusion of the tricuspid valve. There is no communication between the right atrium and the right ventricle. Other anomalies such as arterial septal defect, ASD, ventricular septal defect, or patent ductus arteriosus, into bracket PDA, are commonly present, and a mandatory right to left atrial shunt exists. The right ventricle is usually small, and the pulmonary arteries may also be small. Blood returning from the body empties into the right atrium and cannot pass into the right ventricle. Therefore, the blood goes through the ASD. Please, the ASD has been said already. So in case we use the abbreviated form, to the left atrium. From the body empties into the right atrium and cannot pass into the right ventricle. Therefore, the blood goes through the ASD to the left atrium. From the left atrium, blood flows to the left ventricles, and a portion of this blood goes to the lungs via a VSD. If a VSD is not present, the blood flow to the lungs via PDA. Infants with a PDA, prostaglandin E1, can be given to maintain the patency of the ductus arteriosus, and palliative surgery designed to increase blood flow to the lungs may also be done prior to total correction. Total repair involves creating communication between the atrium, that is the right ventricle, and the pulmonary artery. There is a lifelong risk for endocarditis. The most consistent clinical manifestation is cyanosis. We've talked about the cyanosis already as the bruised discoloration of the tissues. In conjunction with the tachypnea and dyspnea, tricuspid atresia is uncommon defect, occurring in 2.7% of all cases of congenital cardiac defects. Please move. So this is a diagram here showing the cyanotic heart disease. So we have the truncus arteriosus, and we have atrial septal defects. Please move up. So there's a normal heart here, and with the one that is having the problem here, indicating where the ventricular septal defect is. You could see that there's a yellow line here, 2 yellow lines here, but over here there's a blockage. As a result of that, you will not see the 2 lines in the heart with the defects. So that's a diagram showing the two. And with the normal heart, please go down a little. The aorta is rather overriding on the ventricle with the abnormal one, but with the normal one, there's a clear picture of the ventricle over the aorta. Please move up. Cyanotic heart defect or lesions with mixed blood flow. That is total anomalous pulmonary venous connection. That is TAPVC, in case we mention it in the slide. Total anomalous pulmonary venous connection is also called total anomalous pulmonary venous return. Occurs when pulmonary veins do not connect to the left atrium. Instead, they connect to the right atrium or to one of the systemic vein drainage toward the right atrium, into brackets, such as the superior vena cava or the inferior vena cava. The blood flow pattern, if the heart depends on where the pulmonary vein connects and on the presence or absence of the pulmonary venous obstruction. In all types of TAPVC, the right atrium ultimately receives systemic blood as well as the hypertrophy of the right side of the heart. The only way for blood flow to reach the atrium is through an associated atrial atrial septal defect or patent foramen ovale. Please move up. And with this one, the clinical manifestation, we have cyanosis, a blowing systolic murmur, a venous hum, tachypnea, feeding difficulties, and repeated upper respiratory tract infection. Please move up. Please, that is the end of the presentation.
Okay, thank you. So can you have the class? Can you hear from the class? Is there anything you want them to explain further? Our time is even up to explain further. Okay, so if you are okay with whatever they presented, then good evening to everyone.
Good evening, sister.
Hello, sister.
Hello, sister. Group 8 was to present and they shared their slide. So that's why we couldn't present. Hello, sister.
Anita.
Yes.
It's not on. Shall come.
You said?
Shall come. Why? She's not there again.
Oh, okay. Okay. Thank you.
What's it?
Please, is class over?
Yes, dear.
Thank you.